All right, thank you everyone for joining and welcome to Pathways and Pitfalls, helping youth with intellectual and developmental disabilities in the juvenile justice system move to adult health care. This webinar is coming to you from Family Voices. I'm Nikki Montgomery, the Director of Communications for Family Voices, as well as the ARC's National Center on Criminal Justice and Disability, and the Center for Transition to Adult Health Care for Youth with Disabilities. And we're happy to present some findings from a recent study that we worked on together. Next slide, please. All right, before we get started, I'm going to pass it to one of our interpreters to share about Spanish interpretation that's available for this webinar. Lisette?
Thank you, Nikki. Bueno, buenas tardes a todos. Muchísimas gracias por estar reunidos aquí con nosotros el día de hoy en este webinar, ¿verdad? Les voy a explicar cómo activar la interpretación al español si ustedes desean escuchar en español. Gracias a los organizadores por hacer este un espacio bilingüe. Si están en sus computadoras, por favor presionen el icono del globo en la parte de abajo de su pantalla. En la parte inferior de la pantalla van a ver ese icono, lo pueden presionar, ¿verdad? Si están en su teléfono o en una tableta, haga clic en los 3 puntitos que también aparecen en la parte inferior de la página y seleccione interpretación de idiomas y su idioma preferido, que sería el español. No olviden presionar Done. Listo. Muchísimas gracias. Thank you, Nikki.
Thank you, Lisette. All right, as we go through, I'm just going to do a little housekeeping first. If you need to ask a question or you're interested in asking a question, please use the Q&A box at the bottom of your screen, and we will address those questions at the end. So feel free to do that throughout the webinar. Also, throughout the webinar, there will be a couple of QR codes on the screens for you to download or access resources and the survey at the end, just so you're aware and have your cell phones out and ready. Again, at the end, there will be some time for additional questions and sharing strategies. And if you do need help at all during the webinar, please contact Ian, who is on the line. Ian, please say hi for a second.
Hi, everyone.
There's Ian. You can email Ian if you have any tech questions or tech concerns during the webinar. Thanks. Next slide. All right, so I'd like to introduce you to Family Voices, since that's the organization that's hosting. Family Voices is a family-led organization that's national, and we work on transforming systems of care to work better for children and youth with special health care needs and disabilities. One of our goals is to put families at the center of care and make sure family leadership is part of all that we do, so that we can work for equitable outcomes. And this project that we're talking about today definitely falls in line with that. Next slide. So some of the work here is coming out of a project called Meeting the Healthcare Transition Needs of Youth with Intellectual and Developmental Disabilities in the Juvenile Justice System. And this was funded through a grant from the WIS Foundation. I'm going to slow my speech a little bit so the interpreters can keep up. I do tend to talk fast. All right, for this project, Family Voices partnered with the ARC's National Center on Criminal Justice and Disability, as well as the Center for Transition to Adult Health Care. And that center includes Family Voices, Got Transition, SPAN from New Jersey, and the University of Missouri in Kansas City, as well as the Weisman Center. Next slide, please, Ian. Thank you. So our agenda today is really just a few different things. We're going to talk about healthcare transition in general for youth with intellectual and developmental disabilities. We're going to talk about healthcare transition and juvenile justice. And then we're going to have a panel discussion with some panelists who have some experience in that field and can share their knowledge and some of their best practices and challenges. And finally, we will end with questions and answers. So our objectives today are to make sure that you understand the barriers youth with intellectual and developmental disabilities are facing, especially when it comes to healthcare transition. Also, that you learn about the challenges and support for youth who have been in the juvenile justice system. And finally, to reflect on the knowledge and perspectives of professionals in juvenile justice. So I'm going to start by handing this off to Peggy McManus, who is with the National Alliance to Advance Adolescent Health. And she's going to talk about healthcare transition for youth with intellectual and developmental disabilities, specifically about the needs and the barriers youth have. Peggy?
Thank you so much, Nikki. It's a pleasure to be here today to talk about this important subject. If we can go to the next slide, please. So when thinking about healthcare transition, there's a national survey that collects information about youth with and without disabilities. And prior to COVID, only 20% of youth with intellectual and developmental disabilities received any guidance from their healthcare providers about transition. And during COVID, that dropped down to 14%. So this population is seldom receiving guidance about healthcare transition. Yet the major medical associations, the American Academy of Pediatrics, the American Academy of Family Physicians, and the American College of Physicians recommend that all youth with and without disabilities receive guidance on transition using what we call Got Transition's 6 core elements of transition. And I'll explain that further. And what the data show is that when there is a planned approach, improvements can result not only in health and well-being of the young person, but also their adherence to care, their satisfaction with care, and the continuity between pediatric and adult care. Next slide, please. So what is transition? And we want to often convey that it's more than transfer, and it's more than planning. There are 3 parts to it: the planning, transfer, and integration into adult care. So I'll explain each of these in terms of the services that are recommended. So in transition planning, which typically should start between 12 and 18, youth should be informed about what healthcare transition services are offered in a given practice, what changes they will happen in decision-making at age 18, and what the age cutoff is in their practice. The professional recommendations call for annual transition readiness assessments and education on the self-care skill needs of the young person. As part of planning, youth and families should have a medical summary and an emergency care plan that would be updated each year. And then finally, a plan of care to look at the youth's goals and what their self-care skills needs are based on the readiness assessment. Next slide. So when thinking about transfer between pediatric and adult care, which typically happens between 18 and 21, the services that are important are helping the young person and the family find an adult doctor, put together a transfer checklist that would include some communication with a new physician, updated records, the last transition readiness assessment, plan of care. And importantly, oftentimes it might take 3 months, 6 months, a year before that initial adult visit happens. And so it's really important to determine who is going to be responsible for refilling medicines, and if the young person is sick before they get to their first appointment. And so that's typically worked out. And then we like to see a warm handoff between the pediatric and the adult provider. Next slide. And then when thinking about on the adult side, we again look at it in terms of integration and retention in adult care. And that's typically happens between 18 and older. And on the adult side, the professional recommendations call for the adult practice to put together some welcome and orientation. And that could be given to the youth and families. It could be given to the pediatric providers who are helping to identify adult practices. Also recommended is a pre-visit call made before the appointment to make sure that needed accommodations are made. The initial visit is typically longer. There would be ongoing self-care skill building and updating of a medical summary and plan of care. So these three sets of services, planning, transfer, and adult care, are what is meant to be healthcare transition. Next slide. So the 6 core elements, which are available on the Gut Transition website, include a set of sample tools that can be customized for a practice, putting on your logo. You might want to change some of the questions. So we have the pediatric practice set of core elements where the young person is leaving the practice. We have a set of tools for those who are in a family practice where they won't be leaving. And then we have a package for adult care providers. And for each of the 6 core elements, we have a set of implementation guides to help put these in place. And with Family Voices and an advisory group of family leaders, we produced a transition family guide. And again, with the Family Voices cultural broker group, we made available a very special Spanish version of that document. And finally, I wanted to just make note of the new website for Nikki's grant called movingtoadulthealthcare.org. This was developed as produced and driven by a youth advisory group that SPAN has been leading. And we're very excited about the resources that are there, all specific to youth with intellectual and developmental disabilities. Next slide. So we, as part of our first year of work on this grant, spend a lot of time reviewing the literature on transition and youth with intellectual and developmental disability. And I think that this first quote says it all, this feeling of falling off a cliff. And so most often, the families said that this transition work is left to them. And again, as going back to the original data showing that only 14% of youth with intellectual and developmental disabilities have had a conversation about transition with their healthcare providers. So the families and the young people are left to build self-care skills on their own, navigate health services, figure out about supported decision-making, finding a new doctor, and coordinating care plans. So we have a long way to go in terms of meeting the recommendations for this population as well as others with disabilities. Next slide. So from the literature and from the voice of our youth steering committee, they spoke about the barriers that they faced. And I'm just going to read you them because they're so articulate. I am nervous about being an adult. My doctor only talks to my family and not to me. I do not have enough information about advocating for myself. I have not had time alone with my doctor without my parent or caregiver. I'm not ready to leave my pediatrician. It's hard to find a doctor, an adult doctor. No one explained how my healthcare would change when I become an adult, and my doctor's office does not know how to handle my disabilities. I think we could go in the next slide here. before I go on, I just want to say it has been a pleasure to work with this ACL and with funded effort, and to bring much greater attention to the special needs of those with intellectual and developmental disabilities. So I'll turn it back to Nikki. Thank you.
Thank you, Peggy. And I think Peggy gave us a lot to think about in terms of the barriers that are existing just for youth who are not involved in the juvenile justice system. And so Josh is going to talk to us next about how that's compounded and what that intersection is for youth who are also involved in juvenile justice and have disabilities and are transitioning to adult care. So Josh Branch, I'll invite you on, please.
Thank you, Nikki, and thank you everyone for joining us for this important topic. My name is Josh Branch. I'm the attorney and program manager at the ARC's National Center on Criminal Justice and Disability, where we focus at the intersection of intellectual and developmental disabilities and the criminal justice system, both from a suspect defendant side of things as well as a victim side of things. Let's go to the next slide, please. So, we know that youth with IDD are overrepresented in the juvenile justice system, and that was sort of the impetus of this study, in combination with knowing that their healthcare transition needs are not met outside of juvenile justice systems. There's little to no research on how their transition healthcare needs are met within the juvenile justice system. We know that there's a lot of barriers to adequate care, including, poor record keeping, lack of translation of records coming over, as well as not having enough providers, both outside and within juvenile justice detention facilities. And then we also know that, this lack of healthcare that is provided to them is sort of a compounding issue. It doesn't just stick with them as a youth, but it follows them as they continue throughout their lifetime, resulting in lower health outcomes relative to their non-disabled peers. And of course, there are plenty of individuals in the juvenile justice system who feel that they've not received adequate health care, again, due to staff shortages or lack of providers who are provided to them on a regular enough basis. Can you go to the next slide, please? So as we mentioned, this project was funded by the WITH Foundation, and our goals were to learn more about the healthcare transition needs of youth and young adults who are in the who have IDD, who are in the detention facilities. Also, the opportunities to engage them in leadership opportunities, and then provide critical resources to family members who could benefit from knowing, the different advocacy skills that could be leveraged to receive better healthcare transition needs for their children. And of course, developing tools for the youth themselves to advocate for themselves and, lead their own healthcare transition needs and healthcare needs as they become adults. Could you go to the next slide, please? So we conducted an informant interview and surveys. We interviewed young adults between the ages of 18 and 26 who had IDDs and had experience in the juvenile justice facility systems. They completed the surveys by themselves. Some had assistance from another individual. Some had assistance in terms of having the questions read to them so that the surveys could be more accessible for the young adults. And then we also interviewed juvenile justice staff facility members from across the country. And some of those interviews were conducted in person, whereas others were conducted solely through surveys online as well. Next slide. So some of the key takeaways that we have from our report that you can read and download yourself. Many of the youth did not feel prepared to advocate for themselves as they transitioned to adult care. They were confused about there being two different systems, about what paperwork needed to be filled out, health insurance, and often, were not able to answer questions that were like key to their health in terms of provider care. Interestingly, about 80% of the youth flagged that they learned how to advocate for their medical needs through their mothers, which I think is both really touching and really underscores the impact that the moms held for these youth and that comfort that they provided in advocating for those skills. Youth typically had about 30 minutes to meet with healthcare staff. But interestingly, many facilities, or at least folks who we spoke with, staff members were present during medical appointments. There was a variety of reasons as to why that was the case, but we saw that as potentially concerning if you have youth who are in facilities and there's this power dynamic. Youth might be afraid to express how they might have gotten a bruise or potential abuse that's occurring within a facility. So having staff members consistently present could kind of work against those advocacy skills that we are trying to build up for youth. And then 50% of staff stated that they didn't have procedures to screen for IDD. Oftentimes when we spoke with staff, they relied on receiving educational records, but we know that oftentimes there can be a delay in which educational records are received by staff members. And in that time period, youth's needs are not being met. Next slide, please. Many staff members who we spoke with had expressed frustration with the healthcare transition needs, and they cited some of these problems below. So not having appropriate staff to be healthcare transition or ADA coordinators, that was a pretty consistent problem that we saw across facilities. We know that there's staff shortages, and oftentimes staff members are wearing multiple hats. And unfortunately, when that happens, you have some of these, lesser thought of positions, I suppose, but just equally as important positions that are not being staffed properly, or it's someone who has 3 or 4 hats on and they're not strictly dedicated to this. And you really do need someone strictly dedicated to be an ADA coordinator or strictly dedicated to help with healthcare transition needs. I mean, it's a specialty in and of itself. So it really can't be someone with 5 or 6 different hats on within the facility. Another frustration was youth losing their healthcare benefits, specifically Medicaid, upon entry of facilities. A lot of states have policies where when a youth enters a juvenile justice facility, they lose their Medicaid benefits. And then when they're, exiting and coming, re-entering into their community, there's that delay time in getting re-enrolled into those government benefit healthcare benefits. That causes all sorts of delays in medication, delays in treatment. And of course, we should be building up the kids to succeed when they're re-entering their community. But the way that these systems sort of communicate to one another, it's not leading to optimum success, right? If a child is not receiving their medication, all sorts of things could go awry as a result. There was consistent confusion between navigating the different healthcare system needs between the pediatric system and the adult system. As we discussed earlier, many youth were not aware that there were 2 different healthcare systems, but this also translated to parents as well. Many parents thought that their child was enrolled in Medicare and that should be, enough. When in reality, there are a variety of changes that occur. This became a compounding problem when there was cultural issues or a language barrier where individuals who English is not their native language were particularly confused because there was not bilingual language documents available. And so this process becomes even less transparent, more opaque, and more difficult to navigate. And then finally, reentry plans oftentimes did not include healthcare transition. When youth are reentering into the community, there's often a transition plan that discusses treatment, that discusses medication, programming. But unfortunately, many times these transition plans didn't include healthcare transition, which I think speaks to the lack of this being on the radar for staff members. Next slide.
All right, thank you, Josh. Now we're going to get into our panel discussion. So I'd like to invite each of our panelists to introduce yourself. So I'll start with Caleb, please.
Hi, thank y'all for having me. My name is Caleb Alford. I'm the Director of Community Services here at the ARC of the Capital Area in Austin, Texas. I oversee our guardianship program, our adult case management program, and our juvenile justice services program, which provides art advocacy for students in special education at risk or involved with law enforcement. So we kind of do the whole transition piece here in the Austin area.
Thank you, Caleb. Janitha, please introduce yourself.
Good afternoon. My name is Janitha McNair, and I'm the Executive Director at the Northern Virginia Juvenile Detention Center. And we also have the Care Center, which is a shelter care for children on the same property, but a different building, and it has a director that reports to me. So we provide services to adolescents and children in the Northern Virginia and DC metropolitan area into Maryland even. Thank you.
Thank you, Janitha. And Jeremias?
Yes, good afternoon, everybody. Thank you for having me. My name is Jeremias Silva. I am the Grants Director here with Valencia County and am quite literally embedded in all aspects of the government work here in Valencia, but I found my home with our Juvenile Justice Advisory Board, which receives funding from Children, Youth, and Families Department to allow us to be successful and make partner with local providers to offer services for at-risk youth, or even if they're not at risk, just youth that are wanting education, wanting to seek resources. And I'm happy to be here and happy to take part of this discussion. Thank you so much.
Thank you all and welcome to the panel. I'm going to start with one question that I'll ask all three of you is, why is healthcare transition so important for youth with intellectual and developmental disabilities in the juvenile justice system? So I'm going to shuffle it up a little bit. So Janitha, I'm going to start with you on this one.
Okay. So I think it's critical, right, to ensure that our children, our young people don't recidivate because they haven't received proper aftercare or transition care, right? So having these systems communicate effectively and having our children transition with the level of support and care that they need, medical, mental health, the proper doctors, getting to appointments. Often families are unable to assist in the follow-up care, right? Because they might not have the resource to get a child or a young person transported to a visit. So I think it's critical in not adding to recidivism and not creating a path for our young people where they get lost in the juvenile justice system because of failures and disconnect where they don't get the resources that they need. Thank you.
Thank you, Janitha. And Jeremias, you next?
Yes, thank you, Ms. Montgomery. I would want to echo everything that Ms. McNair said, on the recidivism. But I think the one thing to understand is, these youth, they're up against a wall to begin with, right? And we as leaders in the community need to be able to have resources in place via the appropriate stakeholder discussions. That way I understand where Ms. McNair is doing, and I can understand where Mr. Alford is doing, and we all kind of understand what our roles are and where we can ultimately provide successful routes for these individuals to for continuity of care once they transition from youth to adulthood. And like I said, that proverbial wall that they already have in front of them is something that we collectively can bring down brick by brick. That way they have that smooth transition. So, but yeah, echoing everything that Ms. McNair said. Thank you.
And I love how already we've taken this from an individual level to a systems level approach because it requires both. Caleb, can you chime in on that one too?
For sure. Thank you. Yeah, I totally agree with what both of them were saying. I think it is very important for the recidivism piece, 100%. Having worked on the juvenile side and into the adult side, I think having these services available, transitioning out of detention is so important because these students are going to become adults one day. And so in a way, they are preventative services, and it will end up costing these states and even the citizens being affected by these a lot less hardship and problems later on down the road if they had a smooth transition out of detention and into adult healthcare. We see all the time people who fall through the cracks, continue recidivism because they didn't get proper medical or mental health treatment. They may have missed, maybe not meeting the right person, or the knowledge wasn't there in the people who were helping assist them out of transitioning. So I definitely think it is important too that these systems are communicating and discussing things together to ensure a smooth transition out for these students. Here in Texas, our Medicaid waiver wait lists are about 20 years at this time. So a student who does not get the information early enough can truly, truly miss out on good opportunities because the wait list is so long here. So it is very, very important to ensure the success of them into adulthood so that they don't only live, but they thrive as well. Thank you.
Thank you. Wow, I haven't heard of a 20-year wait list before. Wow. Caleb, I'll come right back to you on the next one. So in your jurisdiction, can you explain any challenges you have experienced with healthcare transition or that you've seen for youth with IDD who've been detained?
Yes, 100%. I think the biggest challenge we have seen has been with a lot of our native English speaking families transitioning into the adult healthcare realm. There aren't a lot of agencies who do have bilingual staff. We've seen more and more of that occurring, especially here in Texas. However, there are a lot of families we meet later on down the road who just weren't informed about anything. They don't realize that their loved one is switching to adult healthcare, or maybe their parent is undocumented, so they're not going to get Medicare from them. They're going to have to apply for Medicaid, but there's no one to help navigate that difficult system. People don't realize it takes 6 months to a year sometimes to get Medicaid. There's doctors here that don't accept Medicaid. So especially for the adult realm, we help a lot of families navigate getting connected to doctors that specifically accept Medicaid because there's just so few of them. Here in Austin, for instance, some doctors don't accept it. So we have families going down to San Antonio to receive dental work because there's not a lot of doctors in Austin that accept Medicaid or for dental work. So really just that has been the biggest thing, is these families just falling through the cracks, not getting the support they needed, and being helped navigate these systems that exist here.
Thank you. That's astounding, and just thinking about how you don't have access to care, essentially. Wow, thank you.
Especially the 10th largest city, sorry, in the US. We're the 10th largest. You would think we'd have it, but we don't.
Yeah, yeah. Jeremias, would you like to answer that one as well? Just about what you've seen yourself about the challenges for you.
Yes, thank you so much, Mr. Montgomery, for that question. You know, the biggest challenge that we see is we lose them. We have the measures in place that are explicitly defined in our grant agreements that say, hey, we have to do a 30-day follow-up, a 90-day follow-up, a 6-month follow-up. But the reality is after 14 days, we lose contact with so many of the kiddos because the phone changed, the residence changed, and maintaining that that ability to track them is what we find so difficult. I mean, we're finding ourselves doing a lot of work within the jail, the adult population, and you know that continuity of care is like, where did they go? How can we maintain adequate contact with these individuals so that we know they're set up for success? And that's been the #1 challenge that we see. And quite honestly too, the other big piece of the puzzle that is hard for us is the transportation aspect of it. So a lot of these kiddos, they want to do it. They want to come to the programs. They want to be a part of the resources that we're offering. However, how do we get them there? And then the big thing about it is us here at the local government the appropriate policies and procedures have to be in place. That way, the correct individuals are transporting these youth to and from the services. We can't rely on local railroad or I forget the one that takes you everywhere. Those companies won't transport individuals unless there's a 24-hour predetermined slot that's been selected for them. So we have a very vast rural community. So trying to stay in contact with those rural areas via transportation and just in contact has always been a big hurdle here in New Mexico.
Thank you, thank you. And I'd love to come back to that transportation issue because I saw you all nodding. So I want to hear more about what you think about that. But Janitha, I'm going to first let you fill in about what you've seen and what challenges you've experienced.
Sure, and I'll try to keep it brief, but this is like one of my pet peeves, right? So the challenges that I've experienced here at the detention center and even in our shelter programs is often because either the probation staff or the social services staff, their social services worker, everybody isn't communicating effectively. And so because of that, the family and the young person gets lost, and somebody thinks somebody else is getting something done for the family, and nothing is happening, even with picking up prescriptions, making sure they get to appointments. And I'm telling you, it's been such a frustration for me that I've started crossing into realms that have nothing to do with detention. I've hired a family transition coordinator who I met through one of the young people here who was a family member who was really engaged, and she's bilingual. So she communicates with my families in Spanish and in English so that our families, so we can find out, one, what are they missing? What assistance do they need? Are we able to help bridge some of these gaps or advocate or help them advocate? Because the biggest challenge is communication. We're not connected, the different entities. We don't communicate effectively, and we haven't developed coalitions. We've got to do that to support, this population. And yeah, transportation, what we have started to do is I have a family member call, a young person call, and they let us know we're just going to get an Uber or a Lyft. It's not the best, answer, but we're going to get them where they need to be, right? And so, we're just doing whatever it takes, including picking up mom ourselves, taking mom to get the medication or whomever, and then because we're just committed to trying our best not to continue to lose, our kids. And so I'll be quiet now.
No need. We're here for the discussion, so thank you. Caleb, I'll come back to you with the transportation question as well. Just what are your experiences around that?
Sure. Yeah, so transportation has been a big issue. We primarily operate out of Travis County, where Austin is located. There is a better infrastructure for transportation in that county. However, we do cover the more rural counties around us, and that has been a huge issue for a lot of those families. Especially those who don't have a car at all and are in a rural area. There aren't really any systems available to bring them to and from appointments. They have to rely heavily on loved ones or their staff. One big issue in the state of Texas is our turnover rate is so high, which I'm sure across the US it really is. For certain services, including transportation for adults, it's $12 an hour here, where someone could go to McDonald's and make $14 an hour, right? So we're just seeing a staffing issue, which has also led into a transportation issue as well.
Wow. Okay, so we're getting these compound issues now. That's a lot going on. Does anybody else want to kind of comment about, like, Janitha, if you have anything else to add about some of the questions we've already answered? If you had anything that popped up as the others were talking.
Well, I wanted to add this, just for food for thought for us here and our attendees. So what I have seen lately is because there's been such a disconnect and because there's a breakdown in communication across these systems of care, I've encountered judges placing young people in my detention center that have no crime or criminal involvement for safety, right? And and we're talking about, you know, our IDD young people. They're placing them here because of safety. So that to me begs the question, where are the other resources? Because we're going to take care of whoever you send here, but this is still a confinement facility where you do not have freedom of movement, right? You do have access to some resources, but it can be traumatizing to be placed here. So the idea that it's helpful in any way, shape, or form is troubling. And so I just wanted to add that.
And the implications of that for community inclusion for people with disabilities, right? Like that's the opposite of what we should be doing. Thank you for that comment. That's shocking to me.
I wanted to echo something on that too. I think that's something we've seen a lot too, is like either a residential treatment facility or detention are the options. And we've even seen students come out who didn't even get diagnosed with an intellectual disability or even autism, but probably did actually in fact have it, but they were seen as someone who had trauma. And that was their label they were given. So they kind of floated through the cracks constantly until someone finally met them and heard their story and was like, huh, have they ever been tested for autism? Have they been tested for IDD? Never. Even they've done psyche evals. I've met one student who had a psyche eval a few months back. They never did an IQ score. So I was like, so you did a psyche eval, but never did an IQ score. So there's just this things are being missed. And so these students are really falling through the cracks and are the ones that are having to live with these situations because of these systems failing on them. And it's super unfortunate. One thing I tell people all the time is in our state, we offer a crisis diversion to skip the wait list, that 20-year wait list for kids or adults at risk of harming themselves or others. Not many people know that even exists, and it will allow them to skip that 20-year wait time to start getting HCS Medicaid waiver services into adulthood. That's just that knowledge of that existing is just not out there. And so that is a part of what my agency does, is we really help try to educate the community at large about these systems and how to navigate them to ensure these students aren't just falling through the cracks, because it would benefit many, many of them.
Thank you. Thank you for sharing that. And I wonder how many other states have that kind of, I guess, benefit really to help youth and get past the astronomical wait list. So yeah, thank you for sharing that. All right, I'd love to ask each of you next, what kind of challenges a youth or a child with intellectual and developmental disabilities might face if their post-detention treatment is interrupted or disrupted? And that's something, it's just the why of why we're doing this. I'd really love for you to dig into the details of what does that look like if they don't get this treatment. Jeremias, I'll start with you this time.
Thank you so much, Ms. Montgomery. Unfortunately, here in Valencia County, we have several underserved communities. So when these kiddos do not get the treatment that they need, we kind of know where they're going. And it leads to further understanding on why those communities are in the shape that they're in. Because the governments, we don't have the ability to implement outside the box ideas, right? Like we tried to do a telehealth, right? Implement telehealth in some of our rural communities, but darn it, we don't have the necessary broadband infrastructure to have that. So then we kind of had to go back to the drawing board, seeing what community centers we had available, establish the Starlink, right? Because the Starlink it's on all the time. So now that the community centers have the applicable infrastructure to host these telemedicine visits, now it's getting back into the community, having the stakeholder meetings, letting the people who should be part of the discussion know, hey, ring ding ding, we need your help, we need your services here. We do everything we can, Ms. Montgomery, to have resource events at our local schools. We partner with our sheriff's department, with local law enforcement agencies to bring awareness on what we have out there And the biggest thing, I think, Ms. Montgomery, is being that squeaky wheel to our congressional delegation, to our local representatives and senators, and really be able to paint that picture to them. That way, as they make their way to Washington during legislation time and the discussions come up about funding, those representatives, those senators can be just as informed and, dare I do say, intimate on the problems at hand, that they could quite literally be ready to vouch at a given moment, say, if give me a good idea. And we've been in that position to where our representatives have been aware and have been able to speak during the legislative session on why they're asking for the money, but more importantly, be able to justify the need for these funds to go back to the kiddos and like Mr. Alford said, set them up for success.
Thank you. And Janice, I'll come to you next.
So, certainly, if post-detention treatment is ineffective or interrupted or disrupted, then we're going to have a young person that becomes disconnected from their, critical, from family, might be disruption in the home, behavior, acting out, isolation, being sent to live with a relative. All these things start to happen, get disconnected from school, much needed education services. And then that leads to referrals that might not be appropriate, right? Certainly if you're referring a child to probation or back into a detention center, when really what we needed to do was ensure that the treatment that they needed, post detention is taking place, is effective, right? Is being accessed, and really identifying who is going to support these families and our young people, who's going to be advocates and people that they can depend on to connect them if services are lacking or are difficult to access, right? We need to know going into this planning, into reentry planning and coordination of services, who's responsible to keep the services connected to our families and our young people. And until we do that, then we're going to run the risks of these very often disruptions happening.
Thank you. I hear like coordination here. And then Jeremias, your talk about just getting the government involved in this, like this is not something where families should stand alone. I think that's really important across the board here. So thank you both for bringing those points out. And Caleb, I'd love to hear from you about kind of that personal experience of what the impact is of not getting the services.
For sure. Yeah, definitely, like getting the interruption in medical treatment coming out of detention is very difficult for these families, especially students who are on the spectrum or have an intellectual disability. Going from a structured environment where they're consistently being given medication or whatever treatment it is, to them being thrown out into the world, being told good luck almost. They go from a structured to non-structured environment, and it can cause an exacerbation in behaviors, continuation of recidivism in criminal matters. It just can really make things crumble. A lot of times we have seen students who come out, and because of the issues with finding a doctor who can provide the needs that they were getting or the medication they were prescribed in the detention center, it just isn't always there. There is that fall off. And so we have seen that increase in behaviors, which is really unfortunate. And I do think too, because the school system doesn't always necessarily speak with the juvenile probation departments or the department in general, there is that gap in communication, which then results in the student not benefiting in the future. I do think it would be important for them to include a healthcare transition in the transition ARD meeting when planning that transition out of high school. I think that would help a lot of students out. But we have definitely seen a lot of them just struggle coming out of it. And because of not knowing how to navigate these systems, they're just floundering almost, and it's unfortunate.
Thank you. And Caleb, I do want to kind of circle back to one of the things you mentioned earlier about diagnoses. And there's already kind of an intersectional thing about diagnosis and timing and all of that. And so how do you see that playing out and in this whole process?
I think it's hard because it's like, where did it get missed, right? Because I mean, I've seen 17 to 18-year-olds who just hearing their story, being like, that sounds like autism maybe, but somehow never got evaluated for it ever in their time in special education here in Texas. And it's just, I just think educating the general teacher population and admin and everyone about what to look for when it comes to IDD services. I know for here, I went to University of Texas at Austin, Hookham. They are actually implementing a process where all their teachers coming through for education are being required now to take some kind of special education IDD related curriculum or course so that they are better able to understand or point out or find these students to ensure that they're given the proper supports earlier in life so that these kids aren't missing and just falling through the cracks throughout their whole time in school. So I think that it would be really helpful if more universities and districts required teachers and overall to learn how to identify these students to ensure that they're being caught and given the proper supports ahead of time. Because as we know, preventative measures are so much better than doing it later on in life. It helps them out in the long run a lot more doing it earlier.
Thank you, Caleb. All right, so now I want to kind of get into how do we solve these problems? We've identified a lot of the pitfalls, and some of you have even brought up some of the solutions that you've engaged yourselves. But thinking about this for all of the listeners, how do we solve some of the issues we've identified? So Janitha, I'll start with you, and I'd love to hear, you shared a little bit about what you've done already, but what's still missing and what do you need to see in place in order to feel like you can be successful with this population?
Wow, so that's a big one. So I think we haven't even begun to uncover some of the missing parts that we need for effective to address this problem effectively. But what I've committed to do is to get in good trouble. So, you know, I stay in good trouble. Because I find myself, once it's brought to my attention that a young person or a family that's connected with us has a need, then I'm going to figure out who do I connect you with if connection is the thing, or how do we help resolve it? Like, what do I need to do? And so I find myself and my leadership team, we're participating in, you know, we're doing some probation, social services, case management, right? Because, you know, our probation staff, we've lost so many, they're short staffed, they've got huge caseloads, and as long as a child or a young person isn't the squeaky wheel, right? They're focused on whatever the biggest fire is to extinguish at that point, which is unfortunate because all of our children have the need to be, their cases need to be actively managed. And that requires developing a relationship, right, with these children, these young people, their families, because they might not even be able to articulate really what's happening, but the relationship that you've established with them will let you know something's off. Like, what's going on? What do we need? How can I help make this easier for you, mom? And mom is going to say, I'm babysitting, you know, I have 3 other children at home. I can't get my young person where, you know, so you start to hear the problems. And then I don't ask to hear the problems unless I'm already working on how I can help solve the problem for families. And I get spanked a lot because I'm crossing over into somebody else's territory. But at the end of the day, I can't in good conscience know that one of my kids or their families have this problem if I'm not committed to working to resolve it for them. So I guess in short order, I think we've got to do everything we can from our positions, right? Everything that we have the authority to do and touch and change. And then some of the things we don't have any authority over, just start doing it, right? And I mean, because if I don't, I feel like no one else will. That might be fatalistic, right? But I've been in this business over 20 years. And I think good intentions are always present. But now I'm just going to get in, I'm just going to do the thing. So but it's risky. Everybody can't do that, right? But that's what I do. I hope that answers the question somewhat.
I mean, I think it's risky and courageous. My question for you is how do you do that? How do you fund the things that are not necessarily funded, right? How do you get the staff time on that? I think that's the hard part of saying I'm going to forge ahead, is how do you actually practically do that?
So one thing, so I am not a part, I'm quasi-government. I am fully autonomous. So I am funded by government, but as the executive director, I create my budget and I'm responsible for it. Luckily for me, I've had 6 years out of 7 being here with no budget issues, right? So this last year, we struggled with our budget because I've had more children and I've needed to spend more money on more things. And so I just, I go back and I ask for more money, but if a child needs it, I'm going to spend it, and I'll just be, I'm just kind of lucky. I'm in this box where I can just make the decision and ask for forgiveness. And at some point they might say, you know what? We no longer need your services, ma'am. I don't know, right? But as long as I'm responsible for the children that live here, I'm going to make decisions based on taking care of those kids. And I sleep okay with that. And my poor commission, I work for a commission. Lord, I mean, I'm so sorry they have to deal with me. Because I show up like a warrior when they're like, well, Janitha, your budget is a little, and I'm like, yeah, my population is 3 times what it was. And all of these children show up with high needs and high risks. And of course you send them here for me to identify and meet those needs. So yeah.
Well, thank you for sharing that. I think that speaks to like being in a position where you can make those decisions, or collaborating with the people who can to make changes in that way.
Yes.
Thank you. Caleb, I'll come to you next.
Yeah, I definitely agree. I think being loud and having a voice and making it heard is super important in getting this change across the board. I know I'm the same way. I'm very opinionated. It may not seem that way right now, but I definitely let my voice be heard, and I'm not afraid to let it be heard in any situation involving our clients that we serve, because their voices are many times like not heard at all. So we have the power and the ability to do so. So I make it my mission to ensure that I am speaking for them and up for them too. What we have seen that's been helpful here in this area, at least, as we collaborate a lot with other agencies around our area. Texas has what's called coordinated resource coordination, community resource coordination groups, or CRCGs. Each county has them, they're a mandate, and it requires our local mental health authorities, school districts, PO officers, and other things to come together as a multidisciplinary team of over 30 agencies with experts in the room who hear these hard cases for students who are struggling finding resources. And we put all of our brains together and give resources, and there is some funding and some support they get following that. We have seen some benefit from that in just the education piece. We have recently moved more into our rural county, Williamson County, north of Travis. Just having our knowledge of that crisis diversion I was telling you about earlier, many people in that county didn't know it existed. And so we kept hearing a lot of students coming in, and the first answer was residential treatment facility, this, that, right? Always the most restrictive environment first, not realizing there's least restrictive environment options available beforehand too. And then I think the next biggest thing is really, like, I think Mr. Silva said this earlier, is voting or talking to your legislative people, because it is so important. I think education is power and knowledge is power. So informing them and really truly letting them know what's happening with their constituents in their area is super helpful. I spent a day at our Capitol here in Austin a few weeks back and talked to my reps. It was like speaking to the choir, because they're both on the side of helping these students, but I know that they need that knowledge and that information to then take back to the whole legislative as a whole in the state of Texas. And so I think just really let your voice be heard, and don't be afraid to get a spanking or get in trouble, because you're truly helping impact the lives of people by doing what you do every day. So.
Thank you, Caleb. I appreciate that, and kind of tying it back to the larger picture here of what we need to address. And so, Jeremias, I'm coming to you because you've focused us on that a lot today. So I'd love to hear what your thoughts are on the solutions to the problems that we've identified today.
Ms. Montgomery, if I had the answer to that, we'd be millionaires, right? But I think, you know, the one thing here in New Mexico is like, we're last in everything. You know, we have such a bad rap when it comes to healthcare, when it comes to childhood development, to law enforcement. And, you know, it's real. And it makes it even harder. But the thing that can combat that is what we have inside of us, that belief, that heart, that drive. I think everybody on this call, you're here for a reason, and you need to expand on that reason, and you need to continually ask yourselves every day, why am I doing this? It may be that we have a loved one, a friend. It may just be like me. I was voluntold to get into this type of work, and I'll be darned if it didn't fall exactly into what I should be doing with my life. Okay, so to everybody's, to Ms. McNair and to Mr. Alfred's point, I, I bug people. I am like a crazy ex-boyfriend, you know, because if I don't get the answer, I'll call your representative, or I'll call the next person in line. So having that drive should be something that is apparent to each and every body, and it should be apparent to everybody that you surround yourselves with. When I had the phone conversation with Mr. Branch some months back, I was like, no, I need to be a part of this. I need to be here so I can convey whatever is in my little tiny brain to try and help the masses, right? So one thing that we here in Valencia County pride ourselves with is we have an outstanding relationship and communication, open dialogue with our schools. If I need something with the schools, if I want to put a piece of paper in the school bus route, I know exactly who I got to go talk to make sure that piece of paper gets into the school bus and every kid that gets off the bus receives that. Now, is it 100% effective? Does that piece of paper go in the trash? Of course, but the chances are we're doing something. Not only do we have awesome dialogue with our schools, but we also stay very active with our juvenile probation office. And it's like we can finish each other's sentences. That's how well and how much time we spend with each other. That way we can ensure the stuff is in place where it needs to be, that the programs are in place. And that's another thing. So if anybody is partnering or has local providers, 8 times out of 10, they're grant funded. And it's okay to hold their feet to the fire. If you tell me that you're going to reduce recidivism by 20% and we're at 9, you know what? We're going to be talking, not to drop you or not to lose the program, but to figure out collectively, what do we have to do to get closer to that target of 20%, right? Or whatever the case may be. So, and also having the ability to change with change. I know COVID threw everybody for a loop, right? In the healthcare world, I mean, in every shape or form. So having that ability to change with change, you know, I know my Juvenile Justice Advisory Board was very, very bothered when I came on board because I started asking questions. Hey, what's going on here? What's going on there? This isn't working. We should look into it. And they legitimately told me, if the wheel ain't broke, don't fix it. But my thing is, well, occasionally we have to ask, is the wheel still, does it still have treads on it? Are we still making progress forward? So everybody on here, like I said, I just look inside, reflect on that, and know that what we have inside, those same kiddos and the same youth, that holistic approach may be something that can benefit them, you know, just letting them know how powerful they are to overcome whatever it is that their life, that they're dealt with in life. So thank you so much, Ms. Montgomery, for the opportunity to answer that.
Thank you for sharing that, and just for sharing that kind of bigger community approach to solving problems. Next, I'd like to invite Peggy back. Peggy, I'd love to hear your thoughts about all of this. Peggy's the expert on healthcare transition, so would love to hear what you're thinking.
It's a really amazing panel. Before this meeting, I was reading with interest a Medicaid director's letter about opportunities to test transition-related strategies for community reentry and improve care transitions for those who are incarcerated. And so CMS is inviting states to submit 1115 demonstrations to test out these pre-release opportunities. And to just give some idea, up to 90 days in advance of a person's release, they would support a benefit package to address health and health-related social needs, including short-term enrollment assistance, pre-release coverage, case management, medication-assisted treatment, 30-day supply of medicines. So this is called the Reentry Section 1115 Demonstration Opportunity, and it was put out in April 2023. So again, I encourage people to check that out as an option. Thank you.
Thank you for sharing that, Peggy. And Josh, I'll invite you back if there's anything you would like to add to kind of tie us off on the panel discussion, and then we'll go into questions and answers.
Yeah, I think just in reflecting in the panels and just everyone's comments, there's no sort of one glove fits all solution, right? I mean, this is a systems process. One of our chief complaints at NCCJD is that there's low identification of youth with IDD at the front end. So you have these kids coming in at the front end and they're not getting services right off of the bat. And then, of course, I think sort of at the back end of things, you have the lack of communication between systems, children losing their healthcare benefits when they come in to a detention facility sets them up for like almost guaranteed failure on the exiting end of things, right? And then in between there's all sorts of things that are happening. I think Jeremiah said it very beautifully, that the folks who are on this call are passionate about this issue, and to sort of just keep folks' feet to the fire as we're moving forward to resolve these issues.
Thank you. And thank you all for participating in the panel discussion. Hang on here because there are questions here in our Q&A box, and I may call you in to answer some of those. So please do. I'll start at the beginning of kind of the first questions in the Q&A box and work my way through. So someone has here, people with developmental disabilities are considered vulnerable in transition until 22. And so is that a realistic chronological target for a successful healthcare transition? I'm not thinking of just right at 18, but thinking of that as a range. And Peggy, I'm going to call you in on this one because I know we talk about transition as a process, right?
Yes. I think oftentimes this question about age is raised, and it's gone back and forth and back and forth. And I think in general, people like to think about a range and like to individualize the decision with a practice. But what's very frustrating, I think, for a lot of families is that, you know, one doctor says you have to leave at 18, and another doctor says you can stay till you're 40. And it's very confusing. And oftentimes what happens is when the transfer to an adult provider happens, the later it goes, the more likely the young person would be uninsured or switching insurances. So it's better to have fewer disruptions. Mm-hmm. So, you know, again, you might have more services on the child side. For example, you might have additional care coordination support. So maybe it makes sense for you to move to your adult provider when you're 19 so that you have two more years of additional care coordination support. Again, you know, It's imperfect, but putting it off doesn't make the problem go away.
Thank you, Peggy. I have another comment here in the Q&A that there's not a reliable screening method for developmental disabilities. And so what do we do with that? The person here mentions that you need to have active case finding as a methodology. And so I'm curious if any of you has had experience with that how are you identifying, or what are the tools that you're using if youth haven't been identified so far? Kayla.
I can just say on that. So I don't know if there's exact tools necessarily. I just have over 10 years of experience working hand in hand with those on the spectrum and just kind of noticing the similarities. Obviously, I'm not a doctor, so I can't diagnose people or individuals, but just seeing the similarities across the board and having had worked with many individuals on the spectrum, and just catching those little similarities that they are having and just questioning it, right? Because I think someone else earlier was saying like just questioning things too, because no one else had questioned it before. And it did turn out, in fact, this individual did have autism and just no one noticed it because I think people were afraid to speak up. And they did insinuate that it was the trauma the individual went through earlier on in life that was causing the problems, not that they had autism with trauma and mental health going on as well. And so those comorbidities are super hard to catch. It is very difficult, but I think just questioning when you see it. And the reason why also I questioned it was this individual had never had that looked into ever before. And I had a packet so I could see based off their history that option had never been looked at before.
Thank you. And I think that speaks for having a personal relationship with the people that you're working with, if you're working one-on-one, so that you can notice some of those maybe developmental signs that were missed before and offer that as an option. I know sometimes depending on the age of the person, it can be hard to get testing and all of that, but good to have eyes on someone and a relationship with someone that allows you to at least make the suggestion.
And can I add
Thank
one more
you.
thing that I meant to add earlier is we work really closely with our local disability-specific agencies, such as the Autism Society of Central Texas, Down Syndrome Society, because these agencies do specialize in these specific disabilities. And I found a lot of success in connecting families directly with them. For instance, here in Austin, our Autism Society has a resource guide that has specific doctors for adults, doctors who work with those on the spectrum. Our Down Syndrome Society also has a list of doctors that work specifically with those with Down syndrome. And so I've found lots and lots of success having our families utilize those services too, because they are the specific disability related agencies. And a lot of times they get a lot of families coming to them who have found an in or found the right person that can work with their loved one. So we've found a lot of success utilizing those supports too.
Thank you. Thank you for sharing that. Looking through at some more of the questions, someone asked, are any of these services reimbursed that you provide, and what does that look like? So the healthcare transition services and moving youth to adult care with even the transition coordinator. So Janisa, how that family transition coordinator that you have, how is that reimbursed, or is it?
So that position itself is not reimbursed. I worked it in. Every year I have to submit critical staffing requirements, and I have worked that in as a critical staff member because what we have found is there is a lack, right, in that connection for our kids and our families. And the more we are able to connect our kids and our families with services and communicate effectively with them and provide supports with them, the more we see positive results. I hope that turns into less time, right, in detention. But while they're here, I want to make sure that every resource that they're entitled to access while they're here and beyond their stay here, that they're connected to those. And this position is critical in doing that.
Jeremiah?
Yeah, thank you, Ms. Montgomery. I'd like to kind of express on that question. So the fact is, there is grant funding for everything that we're talking about. There's billions of dollars out there, whether it's state funding through your Human Services Department or federal funding through COSUP. I mean, it's out there. You just have to take like 10 hours of your life to go through grants.gov or any of the other grants services to find what it is that would work for you. But you can't just be naive and apply for it. You have to have the necessary pre-planning activities in place to make sure what you're wanting to do is deliverable, measurable, sustainable, and, you know, through contract compliance, the more you show funders that you're good at doing what you said you're going to do, at adhering to the black and white that it accompanies every grant agreement, the more they're going to be looking your way to say, oh, wow, Miss Montgomery, she delivered. Mr. Alford, he delivered. And they're going to give you extra consideration when you come knocking at the door the next time. So, you know, it's important to crawl, walk, run with these type of initiatives. I've seen so many times where folks have quite literally bit off more than they can handle, and they unfortunately are unable to deliver on what they requested, and then be in a position to have to, sorry, I got to give you this money back because I didn't do my homework efficiently. So just wanted to kind of get that out there as well. Thank you, Ms. Montgomery.
Thank you. That's an excellent point, that there is funding available. Thank you. Janitha, I'm coming back to you because the next question relates to, you said that sometimes youth are placed in your facility for safety. And so in the Q&A, someone asked, what do they mean by safety? Or is this a form of institutionalization?
Okay. So what I have seen it to be in response to is often a child who consistently runs away from home, ends up being trafficked, lots of human trafficking in this part of the country here in DC, Baltimore, Northern Virginia, and for our younger people, especially our younger people who might have experiences with developmental disabilities or intellectual disabilities. So often when the courts see that this child is consistently in unsafe situations, right? They've been placed at shelters or group homes, you know, or less restrictive placements, and they've run or been picked up by somebody who is victimizing them, and then they're, you know, trafficked or mistreated. So I'm not saying the judges do it willy-nilly, right? But it is done often enough, and I've had kids come show up back at the front door themselves. We can't let them in. We call probation and we call Department of Social Services, we call parents, but our kids, our young people are not finding safety in the community for whatever reason, at home or at a placement. And once they get back before the courts after having been missing for 3 months, or, you know, then it's almost gut instinct for the judge to say, I need this kid safe. We need to get you back on your meds. We need to get you evaluated. We need to figure out a plan. So we're going to place you in detention while we work the, you know, not saying it's the best, it is not the best strategy. It is not. We need more resources, whether they're therapeutic, temporary. When I worked in Maryland, we had therapeutic foster care for our emergency foster care. There were resources where people were trained and ready to respond to these unique situations that we find ourselves, but depending on detention, a lot more now. And so that's really what I was referring to. And it's happening. It happens at least 5 to 7 times a year with me, at least. Yes.
Wow. Thank you for sharing more about that kind of process and the logic behind it. So I'm looking here to see, oh, I'm sorry, Josh, please.
I just wanted to add very quickly to that.
Sure.
And Janitha, lightly touched upon this. In our report, in interviewing staff members, several of them flagged that oftentimes, if there are not treatment facilities in the community specific to the child's IDD, whether it's autism, Fragile X, whatever it might be, or a therapeutic treatment, that the juvenile detention facility becomes the default placement for them. Often states have policies where they have to exhaust all state facilities before they can send them to, an accurately appropriate facility. So, if you're in New Mexico, let's say, for example, and there's no placement for the child in the community in New Mexico, they might be placed in a facility until something opens up, even though there might be a place in, say, Arizona or something like that, where a child could be placed outside of a detention facility that's more appropriate. That came up pretty frequently from juvenile justice staff across the country as being pretty problematic.
May I add on that too? We've actually seen that a lot here in Texas. We've had families where their children have been sent out of state. Their children have been sent across the state to Houston or further out just because those were where the available beds were at. I have seen them going to detention too, but something that the state has been trying to roll out more is like emergency respite shelters almost, where it's not fully foster care, but they have a time where they can be there for a short period or for a weekend or a week or something, I think it is, and come as many times as they need to, just to offer a safe place other than going to detention. I think they're trying it out in San Marcos and the Waco area, and I've heard some positive movement on that part, which is pretty awesome. And then we've even seen a student in our programs who got the crisis diversion to skip that 20-year wait list I was talking to y'all about, and got what's called a host home to live in a home with a family who had the structure and the ability to take care of her needs. And just being with them for 3 to 4 months, she was able to return back home with her family and has now been living with them for 2 years just fine. She just needed that. That's not for everyone, right? But that at least that system and that availability for her to skip that 20-year wait list to then get the preventative in the community services really allowed her to stay in the community. So I just wanted to share that too.
May I say
Go ahead,
something?
Janitha. Yeah.
Yeah, I think that's what's missing is flexibility in the system, right? And finding out what an individual needs and individualizing an approach and not just saying, oh, well, we only have this. Like, how do we shape the resource around the needs of our individuals? And so one thing that we are looking at is, so I'm a 70-bed facility. But when I came here 7 years ago, I might have had 12 kids, and that's ticked up, for a while, but I have just over 40 today. But I have a whole unit that is not in the secure area of the facility that's not really utilized. So we have considered bringing in architects and resources to make that unit trauma informed so that it can be used for respite care, emergency shelter, making sure we have the resources, because we know we have a need. Now we just need to, we have the space, we have the need, we need to find support for the funding and staffing that. So, I think people are starting to think a little differently. We just need them to think, make it happen, right? Like right now.
Thank you, Janitha. All right, I'm going to thank you all. We're almost at our time today, so I want to give us a chance to respond to the survey about this webinar. So Ian, if you'll flip to the next slide for me. He's also going to drop a link in the chat. So I'd love for you all to just share. There's just a couple of questions about how you experienced this webinar today. And while you're doing that, I'd love if any of our panelists would like to share some final remarks.
This is Peggy. I again, Nikki, the great kudos to you and to the WITH Foundation for putting bright light spotlight on this. And you couldn't have chosen 3 better panelists to tell the story. So hats off to all of you. Thank you.
I agree, Peggy. Thank you all for sharing your stories and just your solutions and creativity. I think that is what it's going to take to get out of the silos and red tape and all of that. And so I think you all have shared some wonderful ideas, and it's up to all of us who do have that passion to keep moving the work forward.
I just wanted to say thank you for this opportunity. Thank you for the questions and the opportunity, like I said, to answer those. I did put my email address in the chat. Should anybody have any questions or desire to have a offline conversation, feel free to reach out. Be happy to chat with you, just to kind of convey what we're doing here in New Mexico and how it can kind of assist you. Because of one thing that we realized is you don't have to start from scratch. There is a baseline somewhere that you can reference and plagiarize a little bit, so it can ultimately work in your benefit. So thank you again, and thank you, Ms. Montgomery, Mr. Branch. Appreciate this.
All right, well, I will thank you all. I hope everybody's had a chance to fill out the survey. Thank you for joining us, and take that passion forward into your own community and make some change out there. I appreciate you all. Thank you.
Thank you all so much. Y'all have a great one.
You too. Bye-bye.
Goodbye.